Usually when we look at a patient's lab report, there is this, I don't know, expectation of precision. Like it feels entirely binary. You see a potassium level of 6.5, and the alarm bells ring. It's high, it's dangerous, you fix it. A very clean equation.
Right. Exactly. We rely on that. We like our diagnostic data to be easily categorized into normal and abnormal so we can just, take immediate action.
But then you step into the world of dyslipidemia and cardiovascular risk, and suddenly that clean binary thinking just completely falls apart. We're looking at a diagnostic landscape that is honestly a murky swamp. And for a PA student prepping for the PANCA board exams, well, that swamp is full of trap.
Oh, it really is. It's notoriously tricky.
So today, our mission for this deep dive is to navigate that murky water. We are going to master the pharmacology of lipid management, getting away from rote flashcard memorization and focusing entirely on clinical reasoning and pattern recognition.
Which is really the only way to build a functional medical mind, I mean.
Yeah, absolutely.
So to keep us on track, we have 3 specific learning objectives to hit today for you listening. First, we need to master the clinical guidelines for statin initiation based on patient risk categories, not just staring at raw lipid numbers.
Right. Treat the patient, not the number.
Exactly. Second, we will break down the major lipid-lowering drug classes. We'll look at their mechanisms, how and why they actually work on a cellular level, their clinical benefits, and the specific side effects that examiners absolutely love to test.
And third, we will identify the critical contraindications to keep you from falling into common testing pitfalls.
Perfect. So let's anchor all of this in a real patient scenario.
Okay, picture a 45-year-old male. He has a documented history of type 2 diabetes mellitus, but absolutely zero history of cardiovascular disease. He comes in for a routine checkup, and his fasting lipid panel shows an LDL cholesterol of 120 milligrams per deciliter.
Keep this specific patient in mind as we go, because figuring out what to do with him isn't just about, passing a multiple choice test. It's about a pharmacological decision that will fundamentally alter his lifetime cardiovascular risk.
It's huge.
It is. So before we even consider handing this 45-year-old a prescription, we have to step back. We need to know if he even requires therapy and what is actually driving his lipid derangement. Not all high cholesterol comes from a diet heavy in saturated fats. You have to develop distinct illness scripts here.
Right. Like when a patient presents with isolated hypercholesterolemia, you have to actively rule out secondary causes. You should be looking for underlying hypothyroidism, evaluating for pregnancy, or checking for kidney failure.
But if the patient presents with hypertriglyceridemia, meaning just the triglycerides are shooting through the roof, your differential diagnosis completely shifts. Your brain should immediately jump to poorly controlled diabetes mellitus, alcohol use disorder, underlying obesity, or medication side effects.
Like from oral corticosteroids or estrogen therapy, right?
Exactly. Those are major culprits.
That distinction alone is a massive board concept. But even before we get to diagnosing the secondary causes, there's the screening process itself, which feels like a continuously moving target. I mean, the American College of Cardiology and the American Heart Association, the ACAHA, state that it's reasonable to assess risk in adults aged 20 to 39 who are free of cardiovascular disease.
Yeah, and they recommend starting that screening at age 20 to 25 for males and 30 to 35 for females if there's a higher risk present, like concurrent hypertension or a strong family history.
But then you contrast that approach with the U.S. Preventive Services Task Force, the USPSTF. Their methodology is different. They strongly recommend routine screening for men starting at age 35 and women starting at age 45, specifically if they are at increased risk for coronary heart disease. It leaves clinicians with considerable controversy regarding the absolute optimal age to initiate these conversations.
It definitely does, which brings me back to our 45-year-old anchor patient.
Right, his LDL is 120. Honestly, 120 doesn't sound terribly high in a vacuum. Are we just trying to treat a specific LDL number? Like we're aiming for a high score by driving that number into the ground with medication?
No, and that's a common trap. We're not treating numbers, we're treating risk. The entire crux of clinical reasoning and lipid management is based on calculating a 10-year and lifetime risk for having a fatal or non-fatal myocardial infarction or stroke, rather than relying on strict LDL targets.
Okay, that makes sense.
So there are 4 specific patient groups where statin therapy is definitively recommended, regardless of where their LDL happens to sit on that lab report.
Let's walk through those 4 groups, because this is the foundation of cardiovascular pharmacology. Group 1 is straightforward. Anyone with any form of clinical atherosclerotic cardiovascular disease, or ASCVD. If they have had a heart attack, a stroke, or suffer from peripheral arterial disease, they get a statin.
Right. Group 2 includes anyone 21 years or older with an LDL level of 190 or higher. That is a massive, dangerous elevation. It almost always points to a genetic anomaly, like familial hypercholesterolemia, and it warrants highly aggressive treatment to bring that baseline down and prevent early cardiac events.
Okay, and group 3 covers patients with type 1 or type 2 diabetes mellitus who are between the ages of 40 and 75. And wait, look at our anchor case. He is a 45-year-old male with type 2 diabetes.
Yep, he falls squarely into group 3. Even though his LDL is a seemingly benign 120, his diabetes and his age automatically place him in a high-risk category for cardiovascular events.
Wow, so the metabolic state itself is the actual risk factor.
Exactly. The diabetic metabolic state creates an environment of profound endothelial dysfunction and oxidative stress, which drastically accelerates atherosclerosis. That physiological environment is why he needs the statin, not because of the 120 LDL.
That makes perfect sense. What about the fourth group for the patients who don't fit into those first three categories?
The fourth group relies purely on the 10-year estimated ASCVD risk calculation. This applies to patients aged 40 to 75 who do not have diabetes or known cardiovascular disease, and whose LDL sits somewhere between 100 and 189.
Got it.
So if their calculated risk is very high, meaning a 20% or greater chance of an event in the next 10 years, you initiate high-dose statin therapy. If it's high risk between 7.5% and 19%, you use a moderate to high-intensity statin. And if they're intermediate risk, meaning 5% to 7.4%, you rely on shared decision-making with the patient, discussing the pros and cons, though a statin is usually suggested.
So applying this logic to our patient, he qualifies purely based on his diabetes and age, placing him in line for a moderate intensity statin.
Precisely.
So if statins are the foundational first-line defense here, we need to look at how they actually work under the hood. They are HMG-CoA reductase inhibitors.
Right. They prevent the synthesis of mevalonate, which is the very first and rate-limiting step in hepatic cholesterol synthesis. By inhibiting that specific enzyme, intrahepatic cholesterol levels plummet.
The liver senses that sudden drop and essentially goes into a state of panic. It requires cholesterol for basic cellular functions like producing bile acids and maintaining cell membranes.
Yeah, so to compensate for the sudden lack of internal cholesterol, it increases the transcription and turnover of LDL receptors on its surface. Those receptors then act like a massive biological vacuum, pulling more LDL and VLDL remnants straight out of the systemic circulation.
That is a great visual, but the true beauty of statin therapy lies in its pleiotropic effects, right?
Oh, absolutely. Statins provide direct cardiovascular protection that extends far beyond just lowering lipids. They actually stabilize the fibrous cap of coronary artery plaques, making them significantly less likely to rupture and cause a thrombosis.
Which is huge.
It is. Furthermore, they reduce the inflammation intimately associated with those atherosclerotic plaques by dropping the circulating levels of pro-inflammatory cytokines, and they demonstrably decrease C-reactive protein.
So they're actively calming down the inflamed endothelium. Let's break down the drug tiers, because it's vital to know which statin provides which level of intensity. For high intensity, meaning drugs that reduce LDL by a massive 50% or more, we have rosuvastatin, which is the most potent agent available, and atorvastatin.
Right. For moderate intensity, which our diabetic patient would likely receive, you would reach for pitavastatin or simvastatin. Those reduce LDL by about 30 to 49%.
Finally, you have your low-intensity options, like fluvastatin, which is the least potent and reduces LDL by less than 30%.
Exactly. But compliance is always an issue, so we have to talk adverse effects. Musculoskeletal issues are a massive factor here. Myopathy, presenting as bilateral myalgia or muscle aches, happens in up to 10% of patients.
And in rare severe cases, it can progress to myositis with elevated creatine kinase or full-blown rhabdomyolysis. If a patient has a history of myopathy, do we just abandon statin therapy altogether?
Not usually. Once their initial muscle symptoms resolve, rosuvastatin and pravastatin are considered the safest options to try next. This is because they are more hydrophilic. They don't penetrate skeletal muscle tissue as easily as the highly lipophilic statins, like simvastatin, which tend to cause more muscle toxicity.
That is a brilliant clinical distinction. Let's talk about organ function. Mild elevations in liver function tests, or LFTs, are common, though severe hepatotoxicity is actually quite rare.
Right, but renal dysfunction is a classic scenario you have to navigate. If you have a patient with severe chronic kidney disease, atorvastatin is the drug of choice because it's primarily excreted via the biliary system in the feces, meaning it does not require any renal dose adjustment.
Wow, okay. Keeping atorvastatin in mind for your renal patients will save you both in practice and on exams. I do have to push back on the diabetes aspect, though, because this feels contradictory.
How so?
Well, I remember from cell biology that statins inhibit the biosynthesis of cholesterol, and that cholesterol is structurally essential for the production of GLUT1, the transporter that mediates glucose uptake into the cell. If the glucose can't get into the cell efficiently, it stays in the blood. So, if our 45-year-old patient already has type 2 diabetes, aren't we throwing gasoline on the fire by giving him a medication that might increase his hyperglycemia?
That is a phenomenal clinical dilemma, and it perfectly illustrates the concept of weighing risk versus benefit. Yes, statins can mildly impair carbohydrate tolerance and slightly raise a patient's A1C. However, the cardiovascular protection, the profound reduction in the risk of a fatal myocardial infarction or stroke in a diabetic patient, vastly outweighs the risk of a slight bump in their blood glucose.
Okay, so you closely monitor their A1C, but you absolutely do not withhold the statin.
Exactly. Oh, and one more crucial contraindication regarding statins. They are terogenic. Because cholesterol is vital for fetal development, statins are strictly contraindicated during pregnancy and breastfeeding.
Got it. Okay, I'm going to throw an interactive question out to you listening right now. Put yourself in this scenario. You're managing a patient who suddenly develops severe muscle aches while on pravastatin, and their subsequent lab work shows LFTs that are 3 times the upper limit of normal. You can't just tell them to push through the pain and ignore the labs. What is the physiological next step?
Think about it for a second. You have to intervene immediately. The correct approach is to reduce the dose of the statin, try alternate day therapy, change to a different statin entirely, or switch to a completely different class of lipid-lowering drugs.
Which brings up the next logical step in our reasoning. Statins clearly have a ceiling. If we've maxed out a patient on rosuvastatin and their LDL is still dangerously high, or they simply cannot tolerate the statin-induced myopathy, we can't just keep hammering the liver.
No, we have to attack the cholesterol from an entirely different angle, specifically the gut. Let's look at ezetimibe B. Ezetimibe B works by inhibiting intestinal cholesterol absorption. Specifically, it selectively blocks a protein called NPC1L1, which is the sterol transporter located at the brush border of the small intestine. This fundamentally decreases the delivery of dietary and biliary cholesterol to the liver,
which depletes the liver's cholesterol stores, forcing it to upregulate its LDL receptors once again, pulling more cholesterol out of the blood. As a monotherapy, ezetimibe reduces LDL by a respectable 20%, but we shouldn't use it concurrently with bile acid sequestrants.
No, and that's due to a direct physical interaction. Bile acid sequestrants will physically bind up the ezetimibe within the gut lumen, completely inhibiting its absorption and rendering it therapeutically useless.
Speaking of heavy hitters, we have to talk about PCSK9 inhibitors. Medications like alirocumab and evolocumab, the underlying mechanism here is absolutely fascinating.
It really is.
If we imagine that the liver's LDL receptors are like bouncers at a nightclub, their entire job is to grab the bad cholesterol and throw it out of the bloodstream. But the human body naturally produces a protein called PCSK9, which constantly circulates in the blood, binds to those bouncers, and drags them away inside the cell to be degraded.
And that natural biological degradation process severely limits how much LDL the liver can effectively clear. So, PCSK9 inhibitors are fully humanized monoclonal antibodies that act by binding up all that free circulating PCSK9.
Right. By neutralizing it, the bouncers are allowed to stay at the door. The LDL receptors survive longer, avoid destruction, and continuously recycle back to the cell surface.
Exactly, which results in a massive, prolonged clearance of LDL from the blood. Because of that highly specific mechanism, they are the most effective pharmacological agents we have at reducing LDL, and they manage to do this without substantially increasing the risk of myopathies, unlike statins.
The main downsides are mostly injection site reactions, since they are administered as antibodies, and a very rare, less than 1% risk of neurocognitive effects that were identified in early clinical trials.
Now let's round out the add-on therapies with bile acid sequestrants. These are drugs like cholestyramine, cholestyramine, and cholecalcivelum. These are large, positively charged polymeric resins that a patient ingests, and they bind tightly to negatively charged bile acids directly in the intestine.
Under normal physiological conditions, about 90% of our bile acids are reabsorbed in the terminal ileum and recycled back to the liver.
Right, but these sequestrant drugs block that enterohepatic recirculation entirely, forcing the bound bile acids to be excreted in the feces.
And since the liver utilizes cholesterol to manufacture bile acids, it has to drain its systemic cholesterol pool to replace what was just lost in the stool, which again triggers the upregulation of LDL receptors.
Exactly. Because these resins are strictly localized to the gastrointestinal tract and are not systemically absorbed into the bloodstream, they're relatively safe. But their mechanism creates a predictable cascade of malabsorption issues.
Because they are indiscriminately binding molecules in the gut, they interfere with the absorption of the fat-soluble vitamins, right? A, D, E, and K. And this is the exact mechanism behind a huge clinical complication.
Oh yeah, if you lose vitamin K absorption, you impair the hepatic synthesis of vitamin K-dependent clotting factors, specifically factors 2, 7-IX, and X.
Which leads to a prolonged prothrombin time and INR, significantly increasing the patient's bleeding risk.
They also bind and block the absorption of many other common medications, like warfarin, digoxin, or thiazide diuretics. You have to aggressively space them out, administering other drugs either 1 hour before or 3 to 4 hours after a dose of a bile acid resin. And crucially, severe hypertriglyceridemia is an absolute contraindication to their use.
Wait, why is that?
Through a compensatory hepatic mechanism, bile acid sequestrants can inadvertently increase hepatic VLDL production, which shoots triglyceride levels even higher.
Oh, wow. Okay, let's test our listeners again with another interactive clinical scenario. A 28-year-old female patient with familial hypercholesterolemia discovers she is pregnant. We already established that statins are teratogenic and strictly contraindicated. PCSK9 inhibitors lack robust safety data in pregnancy. What is the safest lipid-lowering medication to utilize for her?
It has to be the bile acid sequestrants. Because they are confined to the gut and not systemically absorbed into the maternal bloodstream, they cannot cross the placenta, making them pharmacologically safe for the developing fetus.
Okay, so we focused heavily on LDL, but we need to pivot because clinical practice demands we know how to effectively target triglycerides and HDL. Let's look up niacin, fibrates, and omega-3s, starting with niacin, which is simply vitamin B3.
Right. Niacin strongly inhibits lipolysis within adipose tissue. By reducing the activity of hormone-sensitive lipase, it decreases the mobilization of free fatty acids traveling to the liver, which ultimately decreases hepatic triglyceride synthesis.
But its true clinical claim to fame is that niacin is the absolute most effective agent we possess for increasing HDL, the good cholesterol. It does this by delaying hepatic HDL clearance.
But patient compliance with niacin is notoriously low because of the side effects. It causes intense cutaneous flushing, a warm, uncomfortable burning sensation, usually presenting on the face and chest.
And the mechanism behind that flushing is heavily tested and clinically relevant. It is purely prostaglandin-mediated. Niacin stimulates the production of prostaglandins D2 and E2 in the skin, causing profound, localized vasodilation.
Which means we can pharmacologically mitigate it. If you instruct the patient to take a low-dose aspirin or an NSAID 30 minutes before they take the niacin, you effectively inhibit TOX1 and KOX2 enzymes, blocking that prostaglandin synthesis entirely.
You should also start with a low dose and have them take it with meals.
Yes, exactly. You also have to be incredibly careful using niacin in a patient with a history of gout. Niacin actively competes with uric acid for excretion in the proximal tubule of the kidney. This causes hyperuricemia in about 20% of patients and can easily trigger an acute gout flare.
Ouch. It can also exacerbate underlying peptic ulcer disease and cause varying degrees of hepatotoxicity. Moving on to fibrates, drugs like gemfibrozil and fenofibrate. These work by activating PPAR-alpha, a nuclear receptor protein that regulates lipid metabolism.
Right, when activated, it drastically upregulates lipoprotein lipase, the key enzyme responsible for clearing triglycerides from the bloodstream. So fibrates are your go-to agents for dropping massively elevated triglycerides.
But they alter biliary composition in a dangerous way. Fibrates increase biliary cholesterol excretion while simultaneously decreasing bile acid synthesis. This supersaturates the bile with cholesterol, drastically increasing its lithogenicity.
Meaning the bile is primed to precipitate and form stones. So there's a very high risk of developing cholesterol gallstones.
Here is a clinical dilemma. If I have a patient with stubbornly high LDL and dangerously high triglycerides, the immediate instinct is to just throw a statin and a fibrate at them simultaneously to fix everything at once.
That instinct will severely harm your patient. You must never blindly combine them. Both statins and fibrates independently carry a known risk of myopathy.
Right.
But when used in combination, especially gemfibrozil, with a statin, the fibrate actually inhibits the statin's hepatic uptake and clearance pathways. This spikes the statin blood levels exponentially, significantly increasing the risk of severe myopathy and life-threatening rhabdomyolysis.
Okay, so keep the statins and fibrates separated. Finally, let's look at omega-3 fatty acids, EPA, DHA, icosapent etha.
These are primarily utilized as an adjunct to diet or maximally tolerated statin therapy for adult patients with severe hypertriglyceridemia, usually defined as triglycerides over 500 or even over 1,000 milligrams per deciliter. They work by reducing the hepatic production of VLDL.
The side effects are usually pretty mild, right? Mostly gastrointestinal nausea, arthralgia, and the infamous fishy burps. But there is a hematological effect to watch out for.
Yes, there is. Omega-3 fatty acids actively incorporate into platelet membranes, which alters their phospholipid composition and mildly impairs normal platelet aggregation. This mechanism may prolong overall bleeding time. So, patients taking anticoagulants concurrently need to be monitored closely for bleeding complications.
Well, we have covered the entire pharmacological landscape. Let's pull all this back to our anchor patient to lock in the clinical reasoning.
Let's do it.
We started with a 45-year-old male with type 2 diabetes and an LDL of 120.
And rather than just looking at that 120 and calling it a day, we recognized his underlying diabetes inherently places him in a high-risk category due to the metabolic environment. We treated the physiological risk, not the raw number, by initiating a moderate-intensity statin.
We chose the statin because it inhibits HMG-CoA reductase, upregulating those hepatic LDL receptors. If he suddenly develops severe renal dysfunction, we'd know to lean toward atorvastatin to avoid renal dosing issues.
And if he developed myopathy, we'd adjust the dose or try a hydrophilic statin like rosuvastatin or pravastatin.
If his statin therapy simply wasn't enough, we could add ezetimibe to block the intestinal sterol transporter.
Or if you needed the most profound LDL reduction possible, we'd look to PCSK9 inhibitors to keep those LDL receptors active and avoid degradation.
If he needed maximum triglyceride reduction, we'd use a fibrate, remembering that the mechanism involves PPAR alpha activation, which carries the risk of cholesterol gallstones.
And if we desperately needed to raise his HDL, we'd use niacin, ensuring we pre-medicate with NSAIDs to block that prostaglandin-mediated vasodilation.
Before we go, let's test you one last time with a rapid-fire summary in the form of 3 board-style MCQs with full explanations. Question 1. Which lipid-lowering agent works by inhibiting the sterol transporter at the small intestine's brush border?
Okay, lock in your answer. It's ezetimibe. Explanation here contrasts it with bile acid sequestrants. Sequestrants bind bile acids in the gut lumen, while ezetimibe specifically inhibits the NPC1L1 sterol transporter at the brush border.
Spot on. Question 2. A patient starting niacin develops severe facial flushing. What is the mechanism of this side effect, and how is it mitigated?
The mechanism is prostaglandin-mediated vasodilation in the skin. It is mitigated by having the patient take aspirin or an NSAID 30 minutes prior to their niacin dose to block prostaglandin synthesis.
Perfect. Final question, question 3. A patient with severe hypertriglyceridemia is prescribed a medication that activates PPAR alpha. Which of the following is a potential adverse effect of this medication?
You should instantly recognize the drug as a fibrate. The correct adverse effect is an increased risk of gallstones because fibrates increase the lithogenicity of bile.
You have successfully synthesized the underlying biological mechanisms with the clinical application. That is how you master this material. But beyond the pharmacology, I want to leave you with a final thought to mull over. We know these drugs modify numbers beautifully, and we have proven they reduce clinical events.
But look at the ongoing debate between the ACCHA and the USPSTF guidelines regarding exactly what age we should start assessing risk and screening patients.
Right.
It reminds us that medicine is not just a rigid science of pathways and receptors. It is an art. It's the complex art of weighing lifetime cardiovascular risk against the very real dangers, financial burdens, and psychological impacts of overtreatment.
So as a future clinician holding that prescription pad, looking out at that murky diagnostic landscape, where will you draw the line for your patients?